Welcome to part 3 of our pulmonary diseases. You can find this on pages 134 and 135 of your Nurse Workbook 2.0. You can also print the page below this video, and this video is intended to give you real-world nursing education as well and go beyond the Nurse Workbook alone. So in this lesson, we're going to talk a lot about our vascular issues with our respiratory drive. So we might have good oxygenation or good ventilation, that air coming into our lungs, but there might be something going on at that vascular level or that perfusion level. So let's jump right into this. So how does pulmonary arterial hypertension happen? So pulmonary arterial hypertension is pressure of the blood in the lungs, and this causes damage to tiny arteries in the lungs that reduces the efficiency of these capillaries. And the right ventricle is going to back up over time and become weak. So the right ventricle will start to fail from the difficulty of pumping the backed up blood. So if we go back to our cardiopulmonary circulation lesson, we're going to remember that the right side of the heart is carrying that non-oxygenated blood to the lungs. Inside the lungs, these arteries are damaged, so our blood is going to start to back up. And this is going to build up pressure. And from the lungs, our blood is going to return back to our left side of our heart with our oxygenated blood. But since this pressure has backed up in the lungs, it's going to back up behind it. So this means that our right side of our heart is going to be taking all that pressure. So our right side of the heart is pushing the blood into the lungs. And when there's a backup here in the lungs of that blood, this right heart is going to face a lot of resistance because it's trying to push that blood still into it. So our signs and symptoms of this is going to be our shortness of breath because we're not having great oxygenation and ventilation and perfusion going on here. This is going to make our patients tired. We're going to see this fatigue. We're also going to see tachypnea, so that shortness of breath. And that shortness of breath essentially is one, because our heart is beating faster, because our body is trying to compensate that our oxygen demand isn't as good as it wants it. So our body raises our heart rate, raises our breathing, so we can try to consume more oxygen quickly. And we're gonna see the tachycardia I just talked about, and we'll see signs of that right-sided heart failure. Our treatment of this is going to be various classes of our vasodilators. So we want to dilate those vessels to allow better flow. And in our end-stage heart failure, we might need a heart and lung transplant from the backup of this fluid and the damage that it's doing to these blood vessels. And typically, we're going to use bronchodilators to help open up our airways. We're going to use diuretics so we can pull fluid out of this space and excrete it through our kidneys. We're going to use our inotropes to help take the workload off of our heart and anything else that can be helpful. And then there is this IV Flolan, and this is if this pulmonary arterial hypertension gets severe enough. So this patient would be sent home with this IV pump. We can give it in the hospital, and this medication has such a short half-life that they need this continuous infusion of this vasodilator to help open up all of these blood vessels. And if this pulmonary arterial hypertension goes on for so long, this can develop into our cor pulmonale. And even though we've talked about this in a bunch of our lessons before, this is when we have right-sided heart failure from pulmonary hypertension. But really, this is when we develop this right side heart failure secondary from another condition. So cor pulmonale can also be caused by COPD or idiopathic reasons, meaning we're not always sure, our pulmonary embolisms, cystic fibrosis, and our ARDS. And our last but important pulmonary condition we can see is a pulmonary contusion. And these are going to be important to know if you happen to see them in your practice. So what exactly is this pulmonary contusion? Well, this is when there's a bruise to the lung parenchyma from blunt force that causes edema and bleeding to the capillaries. And so we call this essentially a lung bruise. So just like anything, this can cause swelling and inflammation and cause edema in our lungs. So as you can imagine, this can cause more problems of our ventilation, diffusion, and our perfusion as well. And there are 3 important things we need to know about our pulmonary contusions, since these aren't always immediate. Number one, there is a 24 to 48 hour delay onset of our signs and symptoms. So if our patient happens to have one of these lung contusions and we send them up to the ICU, this doesn't mean that they're in the clear because they look good now. What this actually is telling us is that in 12 to 24 hours, this lung bruise is going to get worse or could get worse. So that's when we need to be high alert about the patient's condition. Additionally, we want to be alert if this patient is presenting with rib fractures or any visible bruising to the lung region, because this is an indication they could have this lung contusion. And we want to monitor for respiratory distress and provide supportive care as needed. As we always say, we always want to prepare for the worst and hope for the best. This concludes our lesson of Part 3, Pulmonary Diseases. I will see you in the next one.